Thank you, Andre. My brief today is to talk about plantar fasciitis. My aim today is just to run through the recent literature to provide some evidence for our current treatment options and ultimately to come up with a suggested treatment algorithm for plantar fasciitis. As we all know, this is a great nuisance condition. It's a real nuisance for patients, real nuisance for surgeons, and often a real nuisance for people like me who have to present something like this. Plantar fasciitis is a degenerative inflammatory condition affecting the origin of the plantar fascia, and it causes pain on the medial aspect of the plantar calcaneal tuberosity. We believe that it is a fatigue failure problem with repetitive overload causing excessive strain and micro tearing, and ultimately leading to myxoid degeneration and chronic inflammation of the plantar fascia origin. It's the most common cause of heel pain. Up to 15% of patients with foot and ankle problems have this issue, and it accounts for up to 1 million outpatient visits in the States annually. The diagnosis is clinical, and they typically have weight-bearing related pain, which is worst in the morning. There's a component of startup pain, and the pain usually dissipates with initial walking, but then returns again as they with prolonged weight-bearing. They typically have on examination tenderness in the medial calcaneal tuberosity, and they often have a contracture of the gastrocnemius and/or Achilles. The natural history is, in the main, self-limiting, with up to 80 to 90% of patients who will have resolution of the pain or have the pain reduced to a tolerable level by 10 to 12 months. So there are lots of treatment options. There's stretching of the Achilles and plantar fascia, orthotics, night splints, casting, anti-inflammatory, steroid injections, and in that you could also add PRP, platelet-rich plasma injections, ultrasound, and ultimately surgery. So I'm hoping just to run through the recent literature and to try and categorize some of the studies into levels of evidence. I'm sure we all know this. Level 1 is high quality, level 5, expert opinion. And then from this come up with some broad recommendations for the various treatment options. These grades have been suggested by Wright, and we'll find that most of our treatment options come under a B or a C category, and I'll run through this very quickly. There are some difficulties when it comes to interpreting plantar fascia literature because we are evaluating a therapy for a condition which in most cases will ultimately get better. So with any study, there should be a control or comparison group. A lot of the studies dealing with plantar fasciitis often assess multiple treatment options at the same time, so it is difficult to crystallize what's working and what's not. And the usual problems with a lot of orthopedic literature: small numbers, insufficient duration of follow-up, non-validated outcome measures. But having said all that, this is really my summary slide for the whole thing. So there are grade B recommendations, grade B meaning there is fair evidence for the short-term benefit for stretching of the Achilles and plantar fascia, orthotics, night splints, and steroid injections. So there is some evidence for the short-term benefit. In terms of extracorporeal shockwave therapy, the data is conflicting. For platelet-rich plasma, there is really insufficient evidence to recommend this. And finally, there's reasonably good evidence to recommend surgery for the treatment of this condition when it's chronic. So let's talk about Achilles stretching. Porter et al., Foot and Ankle International 2003. This was a randomized study looking at two different types of Achilles stretching exercises. The different types aren't important, but they did look at Achilles stretching exercises for managing plantar fascia. At 4 months, both groups had better ankle dorsiflexion, and this correlated with an improvement in their plantar fascia pain. So they concluded that Achilles stretching is effective in reducing plantar fascia-related pain in the short term. This group, JBJS 2003-2006, randomly assigned 2 patients into either a plantar fascia-specific stretching group like this, or just the Achilles stretching, and they used validated outcome scores. And what they found was that at 8 weeks, both groups improved, but the group that had the plantar fascia specific stretching group had better results. And these results were maintained at 2 years with over 90% of patients being satisfied and none requiring surgery. So based on this, one could say that there is a grade B recommendation for the short-term pain relief in the treatment of plantar fasciitis using stretching exercises. But whether or not this is actually better than not doing anything and just waiting is hard to tell. So there's really no evidence to suggest that in the longer term they actually lead to a better outcome. What about orthoses? This is a large prospective multi-center randomized trial with 236 patients randomly allocated to stretching, various heel pads, and a custom propylene orthotic. They assessed their patients at 8 weeks and found that everybody improved, but the best improvement occurred in patients who had a softer orthotic, so the silicone rubber felt heel pad. They had the bigger improvement, and this was actually better than stretching alone and better than the firmer, stiffer custom polyethylene insert. If you also look, it's the cheaper options that work. You don't need to spend all that money for a custom orthotic. They also found that patients who had to stand for more than 8 hours a day had poorer results. So they concluded that soft, off-the-shelf orthoses were at least equivalent, if not better, than expensive custom orthoses. Soft better than firm. All in all, there is a grade B recommendation, in other words, fair evidence for off-the-shelf soft orthoses for the management of plantar fascial pain in the short term. Again, is orthotic use better than no treatment in the long term? We don't know. Dorsiflexion night splints have been used to treat this problem, and the aim is to prevent gastroc-soleus and plantar fascia contracture. And there are studies, level 2 studies, i.e. prospective comparative studies, which say that they work. There is one level 1 study which shows that there is no benefit. Overall, I would say that there is some fair evidence to suggest that this can be useful. One thing to say is that patients can find the nighttime orthotic a bit cumbersome and uncomfortable, and compliance can be a problem. Steroid injections, this is a randomized comparative trial published in the Journal of Rheumatology in 1999, where they compared steroid versus lignocaine injections. At 1 month, they found that patients who had steroid injections had better results, but the effect was short-lived. Beyond 1 month, everybody developed their pain again. So there is evidence to say that the injection works, but it's only short-term. Platelet-rich plasma is a very in vogue treatment for lots of different conditions at the moment. But in terms of managing plantar fasciitis, there's very limited data. A lot of it, in my opinion, is driven by the media, and there are commercial interests involved in this. In the recent Academy meeting in the States, I didn't attend, but I came across this study. There was a guy called Monto from Nantucket who presented his results, which suggesting good results with platelet-rich plasma compared to steroid injection. But in reality, there is really insufficient evidence for us to say whether this works or not. Extracorporeal shockwave therapy. The principle is to apply high-energy acoustic waves to the plantar fascia. How it works is still unclear, but the theory is that the ultrasound waves causes a micro-disruption of the plantar fascia. This initiates neovascularization and healing. The ultrasound treatment can be divided into low-energy or high-energy treatments. Some of the ultrasounds provide what's called a radial ultrasound treatment, where the energy is focused in a radial fashion as opposed to a focused wave where there is a narrow column of ultrasound of higher energy focusing in a more specific area. If you look at the studies, there are many different protocols. Some have weekly treatments, some have monthly treatments, some have single treatments, some have multiple treatments. There are a number of well-designed level 1 studies, in other words, randomized, prospective, comparative studies, but the data is quite conflicting. There is a potential trend for more recent papers to say that it works, but ultimately the data is still conflicting. An example of a study which shows that it does work, Foot and Ankle International 2010. This is a randomized study, 55 patients. When they assessed their visual analog scale scores at 4 weeks, those who had the ultrasound had their scores improve from 8.5 to 1, compared to placebo, where it only went from 8.9 to 7.4. This is another study, large multi-center randomized trial looking at high-energy ultrasound, and they found that their outcome measure was a 50% reduction in pain scores. And with their ultrasound group, 70% of their patients had a 50% reduction in their pain scores compared to 45% in the placebo group. When I looked at the study, I thought there is quite a large placebo effect, and this raises a number of questions about whether or not I think there is more to this ultrasound treatment that meets the eye when there is such a big placebo response, and whether or not this justifies some of the cost in getting high-energy ultrasound treatment. Other study says it works, other study says it doesn't. So in summary, I would say that as far as extracorporeal shockwave therapy, the data is conflicting. The best regime in terms of how often and how much in terms of the ultrasound dosage is still unknown. There is a possible trend to support its use after 6 months of non-operative treatment, but ultimately it's only a grade C recommendation, i.e. the data is conflicting. We still don't know. So what about surgery? Surgery has traditionally been indicated for chronic plantar fasciitis, which has failed 6 to 12 months of non-operative therapy, and the operations generally are an open plantar fascial release with a neurolysis of the first branch of the lateral plantar nerve, or an endoscopic plantar fascial release. In terms of adjuvant therapy, you can perform a recession of the gastrocnemius aponeurosis if they have significant gastroc tightness. Most studies dealing with surgery for plantar fasciitis are level 4 studies, so they're retrospective reviews. Most, however, show that the surgery works. There is good evidence that endoscopic plantar fascial release provides lesser trauma and a quicker return to work and day-to-day activity. This is a paper in 2004 looking at an open partial release of the plantar fascia with neurolysis of the first branch of the lateral plantar nerve. 23 patients, 25-month follow-up, significant improvement in their pain scores and good results in over 90% of patients. This is a study looking at endoscopic plantar fascia release, published this year in Foot and Ankle International. Retrospective study, 49 patients, where they divided the medial third to medial half, the plantar fascia, and the pain resolved in 37 feet, decreased in 11, and only one patient had a bad result. So in summary, surgery is effective in the setting of failed non-operative treatment for plantar fasciitis. The evidence in the literature, however, is only level 4, but the results are fairly consistent in that patients do well after surgery. So this lends itself to a grade B recommendation, and an endoscopic technique leads to a quicker recovery. The literature does suggest that obesity, work cover, and if you have symptoms beyond 2 years, then your results of surgery can be compromised. Complications for endoscopic plantar fascia releases include infection, like most things. There is a potential for what's called lateral column pain, where following endoscopic plantar fascia release, you might get pain with the calcaneal cuboid joint or the midfoot, and this is usually temporary, and it's thought to be related to the foot accommodating to a lengthened plantar fascia. There is some concern in the literature that the risk of nerve injury is higher with endoscopic plantar fascia release, but this is really not supported in the articles that I've read. My suggested approach is obviously to start with a history, and in terms of the history, I aim to find out how long they have the symptoms for, because this tells me at what stage of the natural history the patient might be. This will then give me some indication as to how long to persevere with non-operative treatment and the likelihood of success with the treatment that you would ultimately recommend. My first-line treatment: stretching the Achilles and plantar fascia, the use of a gel heel pad, night splints, activity modification. I do talk to them about an injection of steroid, not PRP, stressing the fact that the injection provides only short-term relief, and the usual analgesics and anti-inflammatories. I think the key to dealing with these patients when you first meet them is to educate and to encourage. After 6 months, if they're still in trouble, my practice is
usually to reiterate the natural history, to say, look, there's still a good chance that this might settle. I will mention the extracorporeal shockwave therapy, to give them the choice, to give them the option. I will say that the data for it is conflicting. Some patients are happy to try it, some patients are not. I generally will discourage surgery until the patient gets to the 9 to 12 month mark before considering surgery. My preference is to use endoscopic plantar fascia release. This is a diagrammatic view showing the heel here, the toes here. This is the endoscope introduced from the lateral portal, and the hook knife introduced from the medial portal. And these instruments are introduced on the plantar aspect of the plantar fascia before dividing the plantar fascia. This is a quick video. That's the plantar fascia up here. This is the slotted cannula. The camera has been put in from the lateral portal. This is the hook blade. So this is all the thickness of the white structure here is the plantar fascia. That's the knife being inserted, and once the fascia is divided, you should be able to see the muscle belly of flexor digitorum brevis underneath the plantar fascia. This is a very quick operation. I enjoy doing it. I've done about 10 or 12 of these, and I must say that patients so far have been quite happy with this procedure. So in summary, grade B recommendations. So there is fair evidence to support these things: stretching, orthotics, night splints, steroid injections. Whether or not it actually makes a difference to the long-term outcome is unclear. But anything that you do that might shorten their duration of symptoms is useful, and these are all fairly low risk. Extracorporeal shockwave therapy, really the data is conflicting. Platelet-rich plasma injections, there's insufficient evidence. And finally, if all else fails, I think surgery is a very good option in the appropriate patient. Thank you very much for your time.